I know you guys are well into your didactic year portion, so you're pretty familiar with a lot of stuff. So if I'm talking at a slower pace than you want, tell me to speed up. If I'm using terms you've never heard of or acronyms you've never heard of, throw a hand up. Don't let me get 4 slides down the road before you tell me you don't know something. So, because my goal is for you to be able to, because in PA school I always liked when I could listen for 2 hours and feel like I really understood it, and that I just had to review a little bit for my test. And so, please, it's really hard to cover all of congenital heart disease in 2 hours, but I will do my best. I think I have a few slides that cover some chromosomal abnormalities as well, so maybe I can help a little bit with when you get to that portion as well, because I don't know how not to. It just is intertwined in the world of pediatrics. And so this is a pediatric unit, right? Not a cardiology unit. Yeah. Okay. So I know you guys have learned how to do physical exams and all that good stuff, but you can't. So my objectives are just to cover pediatric cardiology. And I'll cover kind of a brief overview reminding you how to listen to a murmur, because pediatric cardiology is the world where we hear murmurs the most. We have nice thin patients and our baby kids are little, so it's easier to hear. I'll also cover cyanotic and acyanotic heart lesions. I'll also cover what heart failure looks like in a child, as well as the common pharmacological agents we use, and the importance of nutrition, growth, and the long-term growth and development in kids with congenital heart disease. So kind of just to get started, why do I care about congenital heart disease? So congenital heart disease is anything that is wrong with the heart when you're born, right? It's something that happens when you're born. And so it includes anything from a tiny little hole to very, very complex, complicated heart disease, and things that we talk about in our world. In my world, we say that can only happen in Oklahoma. We call them Oklahoma hearts a lot. And the reason I say this is 1% of our population. So if you see 100 kids, one of them is going to have something wrong with their heart. And so what we also know is when I was born in the mid-'80s, there were a lot of these lesions that we were still bad at treating. We were bad at doing surgeries. We were still learning the surgical techniques. And a lot of these kids didn't make it. Now our patients are living well into adulthood. So this is no longer a pediatric problem, but a medical problem. And it's a problem that we all need to know, whether you're going to go into pediatrics, you're going to go into orthopedic surgery. I don't want you cutting into a kid with a single ventricle if you don't understand what that is. If you're in an emergency room, in urgent care, I want you to know what these things are, because when you don't know what things are, and your patient's telling you about them, their confidence in you drops quickly, right? And so I want you to have at least heard of some of this. And so what causes congenital heart disease? Vast an array is great. It can be something from a thick heart related to maternal diabetes. It can be a family history, it just runs in the family. It can be related to intrauterine drug exposure. It can be related to kind of chromosomal abnormality. And the more common reason we think is just that unknown, that big arching, we don't know. And so a lot of this just goes back to your embryology and how the heart was formed and why it formed the way it did. So when you talk about murmurs, we get kind of, why do I care about a murmur, and what murmurs do I worry about? And so I get asked that question a lot, and so when you look at it, it goes back to what they tell you. Take a history, take a history, take a history. Look at your patient, how old are they? So a murmur that I hear when someone's 0 days old versus 6 days old versus 3 months versus 6 years is all going to be vastly different in how I care about it. My doctors like to say that 3-year-old with a big bow in your hair who's smiling and giggling and running around your office is a lot different than that 4-day-old, 5-day-old check when the kid's huffing and puffing and just looks like a little puny little putzer. And so that's a big difference. And so that leads into kind of your next thought, which is your feeding and your activity. So what is normal for a kid at that age? Is it normal for them to run and play and go 100 miles an hour? Yes, at a 2 or 3-year-old. Is it normal for a newborn baby to eat with ease and to breathe comfortable? So what's going on? Are they not eating as well? Are they not breathing as well? Are they tiring faster than other kids? Those are all important questions. The other thing is you have to take a family history. So my biggest pet peeve is when I send somebody in, a student in, to take a new history on my patient, and they come out and they tell me all about this kid. and I say, anything in the family? And they just look at me with this blank stare. They say, oh, no heart problems. So it's important that, especially if you're worried about anything cardiac, that you don't just ask any heart problems in the family, because that's going to confuse a lot of people. So you really have to delve into any kiddos in the family with heart disease. So you're ruling out congenital heart disease. Any sudden, unexplained, unexpected death in the family before 40 or 50, because you want to rule out things like long QT, hypertrophic cardiomyopathy, other forms of cardiomyopathy, any cardiomyopathies. And I always can't just use that word, you got to explain what cardiomyopathy is. So you want to ask those questions. And then you want to say, is there anything else going on? Did mom have diabetes? Does the kiddo have any other health problems? Was the kid sick when you heard the murmur? Those things are important, okay? So the other thing I always do is I look before I listen. So you want to look over your patient. Are they of normal height and weight? Are they breathing comfortable? Do they look blue? Are they healthy? Do they look like they're always sick? Know what your patient looks like. The other thing, kind of going back, that you also want to look and see do they have any chest abnormalities. So you guys know what pectus excavatum, pectus carinatum are. You want to know that, because those kind of weigh in your little back of your mind, kind of when you're being a detective. The other thing you want to do is you want to, don't forget to palpate. Don't forget to put your hand on your patient and don't just use the thing in your ears. So you want to feel, do they have a thrill? Do I feel this bounding heave? Do I feel, is my PMI on the left or is my PMI hanging out on the right? Sometimes hearts live on the right, right? The other thing you want to do, if I teach you one thing, feel pulses. Feel pulses, feel pulses, feel pulses. And that's not just, yep, got a good radial pulse, moving on. Every time you see a child, and I would say every time you see anyone, you should feel an upper and a lower extremity pulse, okay? So you especially want to feel like, in babies, I usually feel a brachial and a femoral. And in general, they tell you the first time you see a patient, if possible, you should feel a brachial and a femoral because that's closer to the heart, and there's less likely to form collaterals around covering some kind of obstruction. So you guys know why I care so much about upper and lower pulses? We'll cover it later, but shoot.
Coarctation.
Good deal. What if my arms are different? Do you guys know what that is? Just pad things on. So that's usually if you have some kind of subclavian steel. So if either some kind of surgery has damaged your subclavian artery or something's wrong. So that's why I usually feel all four, because I'm a weirdo. And then just remember to be patient. And then the other reason you feel them on every single patient is you got to get good at it. So you might as well do it every time you touch a patient. If you're out in ortho and you send me a referral for discrepant pulses in the arms versus the legs, I'm really proud of you for remembering to check a pulse and to use your stethoscope. So the other thing is listen. Be compulsive. Do it the same way every time, and practice, practice, practice. If it takes you 10 minutes to get a good exam on a screaming child, it is okay. Practice, be comfortable, use both sides of that stethoscope, move around, go slow. I'm an incher, so I don't just hit my 4 spots. I usually start in my apex and just work my way super slowly over to my aortic position. So be slow, be compulsive, be good at it. So just to kind of remind you, because as I start talking about lesions, if you don't remember how to listen to a heart, you're going to be going, Emily, slow down. So just a reminder, S1 is when your AV valves close, so your mitral, your tricuspid valve close, and it's when your semilunar valves open. So it's when your pulmonary and your aortic valves open. And S2 is when those semilunars close and when you have your mitral and your tricuspid valves opening, okay? Does anybody know if your S2 varies some? So sometimes it splits, sometimes it's not. Do we know why that happens? Somebody said it.
They close at different times.
They close at different times, and why do they close at different times?
More pressure.
Yes, that can be true, but also they close at different times because of how you breathe. So when you're breathing, it affects how your pulmonic and it changes the way it closes. So take a big deep breath, they kind of come together, and you can hear a single S2. You're exhaling, they kind of spread out and hear them different. So pay attention, watch, listen while you do it. S3 and S4 We're taught in adults that those are usually abnormal. Kiddos can have some soft little S3s that are very, very normal. I commonly get told, Emily, I'm hearing an S3, Emily, I'm hearing an S4, and I go in and I listen and it's a widely split S2. So I think it really just comes with practice and listening a whole lot, and I will tell you I was not a good listener when I graduated from PA school. You do not get enough experience to be an expert listener in 2.5 years of PA school. So never feel bad about asking someone else to re-listen to your patient or asking questions. That's why we have supervising physicians when we graduate. That's why we have colleagues, and it's okay to ask questions. So remember how we grade murmurs and how we talk about it. My cardiologist would tell you that I have probably list these in the least important. I have not listed these in the order of importancy in talking about murmurs. I think timing is still the most important thing when you describe a murmur. You want to know if it's systolic, diastolic, continuous, and you want to know those things. My doctors would tell you that after timing, he would not put intensity. He usually would put more the pitch being important, so whether it's high pitch, low pitch, medium pitch, because that tells me what's the resistance to flow. Because really a murmur is what? Just a noise, right? And so and the noise is caused by resistance to flow of some sort. And so knowing the pitch is very, very important. And when you talk about intensity, you talk about grading of murmurs. Somebody I'm hoping has taught you that by this point. But just a real quick going through it is, remember your grading of murmurs, grade 1 is barely audible. You probably cannot hear it very well at this point in your education. We call that kind of the attending level murmur. I like to think by this point I'm at that level of listening. So we call kind of a grade 2. I think anybody can hear a grade 2. I call that kind of my med student, resident murmur. Grade 3 is in your face, kind of loud, very intense. Once you get to grade 4, we start getting some hard and fast, like, yes, you have to have this to be a grade 4. So to be a grade 4, you have to feel a thrill. Think of a thrill like you put your hand on a washing machine or a dryer and kind of get that vibratory feeling underneath it. So that's a thrill. You also get grade 5, you can take your stethoscope and just tip it. Grade 6, you can remove your stethoscope and still hear it. Okay? So that's just kind of a good way to think about murmurs. Remember systolic murmurs, so getting into those. So these are kind of, when I was in PA school, I really liked to be able to quickly look at it. There's a difference, right? There's the way to take a test, and there's the way to actually practice medicine, and there's the way to actually be a good provider and a PA. To take a test, this slide right here is super helpful for you, okay? So this slide right here will allow you to kind of very quickly know what's my systolic murmurs, what's my diastolic murmurs, what are my continuous murmurs, and then you add where are these best heard at, and 9 times out of 10 you can get a test question pretty close, because if someone says the patient has a grade 2 out of 6 harsh ejection murmur best heard in the right upper sternal border radiating to the neck, that is aortic stenosis until you tell me something different, correct? So I think, or you hear of a continuous murmur heard under the clavicles on the left side, that's a PDA. They're not going to ask you about a VT shunt murmur unless they're describing a complete single ventricle to you. So a continuous murmur, go ahead and pick the PDA in a newborn. So those are kind of this is how you answer questions, kind of slide to help you. My one little caveat, and this is something that I find our residents don't know, our students don't know, and nobody ever knows when they come and see me. So what's the difference between a holosystolic and an ejection systolic murmur? Anybody know? So there's this big misnomer in the world of medicine that holosystolic means it goes throughout systole. And that's a very bad misnomer that we've given, that we call them pansystolic or holosystolic, not good names. So what they mean is when you listen, you have S1 and you have S2. So a holosystolic, by definition, means it starts at the initiation of S1 and at the start of systole. So oftentimes you're hearing S1 and then hearing murmur, okay? So it doesn't have to go throughout systole, because that little VSD a lot of times will just sound like a psh, 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 psh noise. And so you can't hear that. Whereas your systolic ejection murmurs, which are oftentimes murmurs related on those valves opening, right, or a valve closing, those are going to be, you're going to hear S1 thin murmur, okay? And so that's kind of when you're actually out in practice and you're talking to your preceptors, knowing the difference between holosystolic and systolic ejection is important, okay? All right, so just real quick, we do have normal heart murmurs, right? And those are important in kiddos. I'll cover kind of the big ones and then just let you know that the other ones exist. And so I always, when I talk to patients and I talk about murmurs, I describe murmurs like a water hose or a water faucet. So just like your water hose, you hear water flowing through it, the same can be said for anything. So you have normal sound of water flowing, but if I forget to screw my hose in all the way, it's going to leak, and that water sound is going to sound different. Drop a hole in it, it's going to sound different. If I pinch it and I squeeze it, it's going to sound different. So when you're thinking about murmurs, think about my water hose, okay? So you have a couple different kinds of normal murmurs. I'm going to focus mainly on the venous hum and the Stills murmur. So your venous hum is kind of a continuous little murmur that's oftentimes heard kind of right up here and right up here. And what that is you're hearing the flow in the veins. Kind of the hallmark of a venous hum is, one, you're going to have a healthy kid, right? So a kid that looks totally fine in front of you. And you're going to have this murmur that is heard when they sit up, but goes away when they lay down. Okay? And it's also going to be this really cool murmur that you look one way and you hear this big loud kind of thing, and then the kid turns their head to talk to mom, and the murmur goes away. And then they turn, the vein opens up, and you hear turn, close, goes away. So it's one of my favorites to play with because I can just move a kid's head and make them go away. A Stills murmur is very, very similar. What a Stills murmur is it's that blood flow across the chordae in your ventricles. So a Stills murmur, I call it the Charlie Brown murmur when I listen to it because it kind of makes this wah, 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 wah. And so it reminds me of the teacher in Charlie Brown. It's like wah, wah, wah. So some people call it like a mouth harp murmur. And so what it is this one is classic. If you don't hear it sitting up, but then you lay down the kid, and then you hear the murmur, it's usually kind of mid-sternal border, and it kind of just makes this wah, wah, wah sound. And it can vary, right? So anything that makes your heart rate go up makes this murmur louder. So if I think I hear one in clinic, sometimes I play a game with a kid and I'll say, hop up, do 30 jumping jacks, and as fast as you can, lay down, let me listen again. And a lot of times that exaggerates my murmur and I'll be like, yeah, I'm right, and I just move on. So the key to these normal murmurs are, your EKG is normal as well, okay? So an abnormal EKG, even when I hear these, I still work at more. Pulmonary flow, just a quick touch on that, is very, very normal, especially in a newborn baby. They've never had blood flow in their pulmonary arteries, so a lot of times they'll have just a little pulmonary flow murmur going out to their lungs in those branch pulmonary arteries that they outgrow usually by the time they're 6 months. And we also hear a lot of carotid bruits in kids. So they just have that increased blood volume, they're pumping a little bit more, so you just hear them a little bit easier. You do not have to do a carotid ultrasound on every 2-year-old you hear a carotid bruit. So when to refer, when not to refer. When you're first starting out, refer frequently. It's okay. We're not going to be mad at you. I'll let you guys read this. There is just one little caveat. We talk a lot about being good fiscal, conservative people with our patients' finances and their resources. And I think it's really easy as providers to just order an echo. I think it's important that you remember that an echocardiogram costs between $2,000 and $3,000 when you order it. It also has to be prior approved by Medicaid. So it's important to remember, one, not all echoes are created equally. And pediatric echo should be done by a pediatric sonographer and should be read by a pediatric cardiologist. Okay? They're done with different hands. Their approach to doing the echo is done differently. We do ours upright, adults do them upside down. It's when we look at them, they look different. And you want somebody who looks at pediatric echoes all the time doing it. The other thing we tell you is that there's been a lot of research that shows that sending, let me get to this. You can read this. This is one of my cardiologists put all these slides in here. So, but you can kind of read through this that the pediatrician or the pediatric PA who just orders the echo is, that's cost about $2,000 to $3,000 versus the number of times we can see them in our clinic doing EKG only and listen and clear them, that we are able to do that with much more comfort and much more ease. Hopefully in the state of Oklahoma, we've gotten, it used to be very difficult to get appointments with us. We've gotten our wait times down from 6 months for a new patient visit down to about 2 to 3, and hopefully in the next 6 months we can get ourselves down to within a month. So from a pediatric cardiology standpoint, we're working really hard in the state of Oklahoma to provide care for everybody. And so we're hiring many, many new people, so hopefully we get there quickly. But that is kind of, I'll skip through this because this is boring and I didn't make these slides. Okay, so when should I refer? If it's not clearly normal and you have a clear abnormal EKG always, anybody with Down syndrome has to have an echocardiogram. That one you can do the echo without calling me, but if you want to, just call us. They should have an echo within the first probably week of life, okay? Remember that, maybe less than that, but I personally don't like, it's not a fun conversation when I see the 1-month-old who has an AV canal that's not been heard, and it's not really a fun conversation with the family at a month-old to explain that. So I tell people we'll get an echo early. So I think we'll cover Down syndrome more. Anytime it's a high-pitched murmur, a diastolic murmur, go ahead and send it to us. If your family history makes you uncomfortable, please send it to us. If they're sick and you need a patient seen quickly, just call. Just pick up the phone, talk to somebody in the clinic and tell them, because we're going to get your patient in a lot faster that way. So we're pretty nice. I'm pretty nice. I'll give you my cell phone. Just briefly talking about heart failure, so after this slide I can just say the kid presents in heart failure. Heart failure in children looks very different than heart failure in an older adolescent or an adult, okay? In adults, we think of heart failure as unable to walk short distances, tiring very easily, they get puffy, they get swollen, they get fluid in their lungs. And some of that is true in kids, but it's very different. And so, especially in a baby, okay? So a lot of what I'm talking about is with babies. So kids have very elastic livers, and so kiddos, their liver will expand as they maintain fluid volume, okay? And they get fluid overloaded. So kiddos will get this very big liver when they get heart failure, okay? So you always want to make sure you're feeling the liver, and if your liver's way down here, that's not always normal, right? So that's important. A kiddo who's huffing and puffing and retracting, and we call this like head bobbing kind of thing going on, is not normal. Kiddos who sweat through an entire feed and who take more than 30 to 40 minutes to eat their bottle is not normal. I don't know, how many of you in here have kiddos? So you guys have all fed a baby. Well, like 2 of you have fed a baby. And so babies eat fast, right? Babies down a bottle, they're excited to eat. They sometimes get that excited fast breathing, that like, give me the bottle, give me the bottle. And then once they start eating, they calm down. But if a baby looks like a panting dog the entire time they're eating a bottle, and it takes an hour to take 2 ounces, that is not normal, okay? So really, really, really don't just say, how much is your kid eating? Ask those questions. The other thing is kids who are in heart failure do not gain weight. So failure to thrive, something wrong with the heart should be somewhere on your differential. Okay, so a lesion with a big left to right shunt should be on your differential. They don't puff, they don't get edema, they don't get pitting edema. Okay? So they can get fluid in their lungs and they can get overloaded. They don't usually get like effusions like adults do. They just get this real wet, hazy, like pulmonary edema, pulmonary congestion appearance on their x-ray. So what causes heart failure? Big left to right shunts is the most common thing. So anything that has some big hole that's causing things to go primarily from left to right and just dumping extra blood flow into the right side of the heart and causing pulmonary overcirculation, that's what we typically see in kids. Because we're talking about congenital, right? So we're not talking about a cardiomyopathy or dysfunction, which is the same as an adult. How do we treat this? The same way you treat it in an adult, okay? So we love Lasix in pediatric cardiology. We use it all the time. I usually start at about 1 per kilo twice a day, so about 2 per kilo per day. You do have to make sure they're eating. So when you give someone Lasix and the kid's vomiting or gets a GI bug, I have to care that they're dehydrated because babies don't like to be dehydrated. So if I really am doing a lot, I'll check my electrolytes. Kind of after Lasix, I usually, in kiddos, will go to Diarrhea. It really helps better with the pulmonary overcirculation, which is hydrochlorothiazide. And then after that, I do aldactone. If it's more of a cardiomyopathy, I tend to lean more towards the aldactone and that adult research that shows that an aldactone will support the function. Digoxin is the medicine in adults that you're taught don't give this very often. It has a lot of side effects, it causes a lot of problems. In pediatrics, it's probably our most well-tested pediatric heart failure medication. It is used, we use it all the time. We use it for SVT, we use it for heart failure, we use it all the time. It's got a great pediatric formulation, it's super cheap. And the good thing is that kids kind of naturally make the digibind, which helps bind against digoxin and helps prevent the digoxin toxicity. So we don't have to check levels in kids very often. I usually check a level if I feel like something's either it's not working or they're doing something weird and I want to make sure it's not high. But very rarely do I check levels. Dr. Baker, one of my cardiologists, made this slide and she likes captopril. I like the rest of us use enalapril. It has a great pediatric formulation. Either way, we use ACE inhibitors. The good pediatric ones right now are enalapril and lisinopril. The only thing is when you're talking about using an ACE inhibitor, if someone has aortic stenosis or a subaortic membrane or a hypertrophic cardiomyopathy with obstruction, you don't want to use an ACE inhibitor if you have LV outflow tract obstruction. Okay. So now we're into the nitty-gritty. Sorry, that takes a while. I apologize. I should feel better. I was 30 minutes late to my lecture at the OU program and I forgot, so I just skipped all of that. So when we start talking now, we're going to talk about acyanotic heart lesions. And so we'll cover kind of the most common stuff first, the stuff that's on your boards, the stuff that's, when they give you the list of lesions, and then I'll get to complex after that, okay? So when we talk about ASDs, we talk about the hole between the top two chambers of the heart, and there's kind of 3 different types. You have a secundum ASD, which is located in the area of the middle of the atrial septum. It's typically in that area where the PFO was. And so you remember your PFO is kind of a flap, right? So it kind of sits like this, and it's a flap that was a part of your fetal circulation. And so sometimes what happens in fetal development is instead of that flap staying a flap so it's easy to close when the baby's born, that flap kind of stretches and they end up with a hole in that area, okay? And so that is the most common type of ASD that exists, is a secundum ASD. The other kind you have is a primum ASD, and that's typically a part of an AV canal defect of some sort, or an end cushion defect. And that's the type of, and we'll talk more about AV canals later, that's the common part. It's down in the bottom part of the atrial septum, kind of right in the middle, in between your mitral valve and your tricuspid valve, and it's usually just a drop out there. It almost always comes with a cleft in the mitral valve, and that abnormality with the mitral valve that you see with AV canals and in-cushion defects. So we call it a partial AV canal when you have a primum ASD and a cleft in the mitral valve, because you don't have a VSD component and you don't have a common AV valve. So the other type of ASD, there's a lot of debate whether this is really an ASD or not an ASD, and it's a sinus venosus defect. And the way I think of sinus venosus defects is if you're looking at your atriums, and say you're looking kind of here at the back of your atriums, and your pulmonary veins typically should kind of all come in here in the left atrium, right? So sometimes what happens is you get kind of 2 of them that decided to come in the wrong place, or they decided to come in, here's where your SVC usually drains, or sometimes they decide to come in here onto your SVC. So the body is smart and realizes that pulmonary venous flow needs to get to the left atrium, so you usually get kind of this dropout here that's allowing that blood to go through it, and that's usually associated with what we call partial anomalous pulmonary venous return. Okay? So it's usually either brought on by kind of your right-sided pulmonary veins coming into your right atrium, your right-sided pulmonary veins coming into your SVC to RA junction. It can come to other places, but that's for the cardiologist to have to figure out. You guys don't need to learn that at this point. So an ASD is typically pretty isolated. We talk a lot about when to close an ASD and when to worry about an ASD. An ASD, because it's low pressure and it exists in between your atriums, and the pressures in your left and your atriums are low, you can go a while to close them. We know that PFOs can they can self-close over the first 3 to 5 years. So we usually don't close an ASD until the kiddo's 3 to 5 to give them plenty of time to close, okay? So you typically close an ASD between 3 and 5. They're oftentimes closed in the cath lab with a device, unless they're so big that you don't have something for the device to sit on, and then they can be a surgical lesion. One of the reasons if you see a small PFO to close it in an adult would be if they've had TIAs or they have an increased risk of strokes. So the research currently is that a PFO exists in about 20% of the human population, and that they are only indicated to be closed if the patient has had a TIA, or if they have an increased risk of stroke, or if, I always tell parents, if they're going to be jumping out of airplanes for a living, or they're going to be a deep sea diver, so that significant change in altitude that can cause the blood to, instead of going left to right, to go right to left, and can increase the stroke risk. It does not increase your risk of having a stroke to have a PFO, but if you have a PFO and you've had a previous stroke, it increases your risk of having future ones, so then you would close it, okay? It's a very controversial topic right now in our world. This is what they look like on echo. And so you can see your right atrium and your left atrium. You can see a hole in between it. So VSD is still the most common cause of congenital heart disease. It's also the most common thing you see in Down syndrome. VSDs are always your answer to the most common cause of congenital heart disease. And so VSDs are just a hole between the bottom 2 chambers of the heart. What I always tell parents is please do not Google VSDs, because VSDs are wide and vast in what they can be and what they can do, okay? So they can be anything from an itty-bitty hole in between the muscular part to a big old hole that has to be closed. And so VSDs are things we follow and things we care about, but what they do for the patient really is vast and wide. So many of them close spontaneously in the first year. Specifically those muscular VSDs. So just like ASDs, there's kind of 3 basic types of VSDs. You have muscular VSDs, which happen in that thick muscular part of your ventricular septum. If you remember your embryology, just wanted to do that. The way your ventricular septum was formed is that from the heart muscle, the bottom half came up, and then the top half came from kind of that truncal area and came down and formed with the membranous portion. So it kind of comes together, and so you can see how it just kind of forgot to finish, and that will happen. The muscular portion, I oftentimes think of those as like muscle, right? It's striated, and it kind of looks like this. And so you can see how it just kind of wasn't quite done, and so it just needed to finish, and so you can get little holes there. I always like to think about what caused my defects so that I can figure out why it's there, and how blood's going to flow. So oftentimes, if they're big though, they're a big hole, so usually over about 5 millimeters is considered big. And so 4 to 5 is kind of that gray zone. Over 5 is big. Those are the kiddos that are going to have heart failure symptoms, and those are the kiddos that are going to need medications to manage it, and oftentimes surgery to close a VSD. Most VSDs, when they have to be closed surgically, are closed in the OR as opposed to being closed in the cath lab. We're slowly starting to do some of the muscular ones that are big in the cath lab, but most of them right now are being closed in the OR. These are your holosystolic murmurs, okay? The key thing I want you to know about VSDs is you can't always hear them at birth, okay? And the reason that is what causes your murmur on a VSD is blood flow from the left to the right across the hole. So when you're born, you remember your pulmonary vascular resistance is high. So your blood pressure on that right side of your ventricle is high and elevated. And your blood pressure in your left side is still, they're pretty equal, right? So when you're born, the blood doesn't have a very good left to right shunt. It's what we call kind of either a low velocity, or it can even be a bidirectional and kind of going both directions. And so you're not going to hear that VSD. So what happens is over the first 4 to 6 weeks of life, as that pulmonary vascular resistance drops, that VSD starts to shunt the correct direction, and then you start to hear it. So these are the murmurs that you oftentimes hear at that 4-week checkup, and you go, wait a second, I didn't hear that at their newborn visit, or I didn't hear that at their 2-week checkup. But that's why we do newborn visits at different stages, is so that we can pick things up. And so parents get really mad a lot of times when it's picked up at that 4-week checkup. They ask a lot of times, why didn't my pediatrician hear this? Why didn't my PCP hear this? And I tell them, because it's not always capable of being heard as a newborn. And so that's also when they will start to have symptoms. So they may look great, they may feed great as a newborn, and then once that pulmonary vascular resistance drops and that starts shunting a lot, they can start having that fast breathing, the big liver, and those heart failure symptoms we talked about, okay? And this is going to be your holosystolic murmur. Remember, the lower the pitch, the bigger the hole, okay? Higher the pitch, the smaller the hole. So a high pitch, holosystolic murmur, left, kind of mid-sternal, left lower sternal border, in a kiddo that's looking pretty good is probably a small little muscular VSD. So this is what they look like. This is where they are. This is kind of more of your perimembranous VSD. This is what it looks like in an actual heart, with the anatomy buffs in the room. This is what it looks like on echo. So this is the heart looking at it upside down, and so actually more of an adult echo. So looking at this, you can see, I can't quite figure out how does this work?
You use the stick.
Got it. You can see the hole. You can see it's labeled for you, the LV and the RV. You can see that. This is a slightly different view, and you can see these are muscular VSDs, and so you can see where the color is where the hole is. So more VSDs. This is what a pediatric echo usually looks like, upright, like it should, good 4-chambered view for the surgeon. This is more pictures. This is what they look like when they're closed. So that's a patch. So that big white thing you see, that's a patch where somebody has sewn a VSD in. So those are VSDs. VSDs are my favorite lesion to fix surgically because the baby goes into the operating room looking super sick, severe failure to thrive, huffing and puffing on heart failure medicine. They come home and may be on some meds kind of for the first few weeks. And then they start eating, they start gaining weight, they do really well. And the long-term follow-up of a VSD is very, very good. And those kiddos do very well. They live normal lives. They run, they play. We do operate in and near the electrical system, and so we do put foreign material in the heart, so they're stuck with us forever. But these kiddos do very, very well. So this is your AV canal defect. And so this is where we talk about Down syndrome. And I know you guys have talked about Down syndrome in other lectures and in other genetics, but I would not be doing my job as a pediatric cardiology PA if I don't bring up Down syndrome here. So remember, 50% of all kiddos with Down syndrome have something wrong with their heart, so they have a congenital heart defect. Of those, 50% of those will have an AV canal defect, okay? So what is an AV canal defect? The way I think of it is they have what we call a single AV valve. So your AV valve normally should be like 2 circles that sit on separate sides. One sits on the left, one sits on the right. And so what happens is they kind of form a bridge or a connection between them, and they kind of end up looking a little bit like this. And it kind of sits right there in the middle of the heart. Well, if you have a common AV valve, there's no way for your septum to finish closing, right? So you end up with a primum ASD, so that big dropout at the bottom part of the atrial septum, and then what we call an inlet VSD, or a big dropout at the top of the ventricular septum, okay? So an AV canal defect consists of all 3 of those components, okay? A lot of times when these kiddos, they'll develop heart failure in the first few months because they have really large holes, and so they end up with a very large kind of left to right shunt. They also have a common AV valve, which is at risk of leaking because it's not normal, and so a significant AV valve leak can also lead to heart failure symptoms. So a lot of these kiddos will end up having heart failure symptoms. If they have a murmur, they will have typically kind of a holosystolic murmur present. They also can oftentimes have a gallop if they're in severe heart failure. And a gallop, if you've never, there's all this, describing gallops. If you want to know what a gallop sounds like, watch a horse gallop. Think of what a horse sounds like when it gallops. It was named for a reason. That is what it sounds like. If you're listen to a heart and it sounds like there's a horse galloping in it, it is galloping. So that's the best way to that is what I tell my students all the time. I say, listen, that is a gallop. That is what it sounds like. The big thing with these is that these don't always have murmurs, okay? And the reason that is if you get a big hole, right? And so it's going to be a very big, so there's not a lot of resistance to flow. So you're going to have this low velocity hole that's there. The other thing we know is that kiddos with Down syndrome don't like to drop that pulmonary vascular resistance, okay? So if their pulmonary vascular resistance doesn't drop, then there's nothing telling that blood to kind of go well from left to right. And so they may not develop, if that pulmonary vascular resistance doesn't drop, they may not develop a lot of symptoms. They also may not have much of a murmur because there's nothing causing resistance to flow. And so a lot of times, us saying every kiddo with Down syndrome needs a good echo, that these were missed. And what happens is, if you don't fix this surgically by the time they're 3 to 6 months in a Down syndrome kiddo, you can end up with irreversible pulmonary hypertension. And that's something we call Eisenmenger's physiology. And that's what used to cause kiddos with Down syndrome to die around 7 or 8 years old. And dying from Eisenmenger's and pulmonary hypertension is a horrible way to die. It is miserable and looks horrible. So when you've read about pulmonary hypertension, it's miserable. And so it is something that you have to fix an AV canal by 3 to 6 months. And this is why we care about what a kiddo with Down syndrome's heart looks like, okay? So long term, once we fix this, what they do to fix it is they close the holes, they put a patch there, and they separate, they usually close the clefts in the valves, and they separate those valves. Fixing the valves, and they divide it. The big thing is you have operated right in the AV nodal area, correct? So these kids have long-term risk of developing rhythm issues. Specifically, they get heart block after this. The other thing where those patches are, you can develop some kind of subaortic membranes, kind of where scar tissue forms where they sewed and along the suture. Sometimes the surgeon needs to go back in and resect out the subaortic area. Several years down the road, they also can develop significant leak of that mitral valve afterwards. I like to say it's hard to make one valve into 2 perfect valves, so oftentimes the mitral valve, because it's under higher pressure, when it's a valve that has a leak and has issues down the road. If you ever figured out pediatric cardiology is a lot of just understanding how blood is flowing, how physiology is working, and so what is wrong with the heart. So when we talk about your RV outflow tract and you talk about kind of obstruction, you can pretty much read this, but just a reminder, kiddos can get, just like adults, but more so on the right side is more common in children, you can get pulmonary stenosis. Those typically tend to be congenital, less acquired, as your RV outflow tract obstruction lesions. These probably should have gone in my cyanotic, but just bear with me that they're here. So this is your pulmonary stenosis, and you can get pulmonary stenosis anywhere. So you can get it, most commonly you can get it at the valve. You can get it supravalve in that MPA, that area right above the pulmonary valve. You can get it in the branch pulmonary arteries. You can get it below, kind of an infundibular, what we call obstruction. And so oftentimes if it's just the valve, we can fix that in the cath lab with a balloon. Otherwise, we fix it in the OR. So the murmur with these are typically your systolic ejection murmurs, or your left upper sternal border. Pulmonary stenosis murmurs radiate to your back and to your axilla. Aortic stenosis murmurs radiate to your neck. So they're really different sides of your chest. So when we talk about your LV outflow tract, do you have a question?
Can you say that one more time?
Yeah.
Pulmonary stenosis radiates to the back.
Yeah, so pulmonary stenosis murmurs, or RV outflow tract murmurs, are going to radiate to your back because of your anatomy, right? So you have your pulmonary artery, it comes up, goes out, right? And then in front of it, usually kind of your aorta kind of comes up and then makes a turn and goes up, but it kind of comes up and shoots up and then has branches that go up and into your neck. So oftentimes your pulmonary, you hear in the back and in the axilla, and your aortic stenosis murmurs, your LV outflow tract stenosis murmurs, they follow the pathway. So as it's coming up and going to your right, it then comes up and goes into your neck. So it's that principle of knowing, thinking how blood's flowing. Draw it out, use your arrows. Draw your heart, draw your arrows. So LV outflow tract obstructive lesions, just like the pulmonary, they can happen in any place. Oftentimes in adults, these are acquired over time. They're oftentimes acquired over like calcification lesions on your aortic valve. These can happen though when you're born too. You can be born with aortic stenosis, just like you can be born with anything else. And so depending on how much it happens is important. And so we talked about these murmurs. The key thing to know is that when we talk about aortic valves, remember you can have what we call bicuspid aortic valves. And the key thing I think when you're talking about pediatrics is that the current recommendations coming out of Mayo is that those tend to run in first-degree relatives. So the current recommendations are that those get screened in all first-degree relatives. And so does anybody know if I don't have any narrowing, any leak of my bicuspid aortic valve, does anybody know what that sounds like on exam? Anybody remember? So remember we have things other than murmurs that make noise in the heart, right?
Rub.
Click, there you go, you said it. Yeah, so I heard it a few times, yeah. So these kiddos get clicks, so they get that ejection, so as that valve opens, it ejects. So remember it's a fish mouth, so think about your hands and how it kind of clicks when it opens. That's how I think of it. I've got a weird brain now, so. So Shones, just don't worry about this. But Shones, pretty briefly, is when you have multiple left-sided obstructive lesions. I don't want you to know the term, because sometimes parents will come in and say, my kid has Shones, and you go, okay, thanks for using the dead guy's name. But what that means is you have several left-sided obstructive heart lesions. So we're really trying to get out of using that term, but it is still used often. So going to coarctation, which is my doctors would yell at me if I didn't spend some quality time on a coarctation. So coarctations are something that are very difficult to pick up prenatally. So these are things that are very often missed in that fetal ultrasound that the OB does, okay? And the reason that is that they're hard to see in the presence of a PDA. So when you have your PDA open, the PDA is providing blood flow to both sides, around the obstruction. So you're able to it makes it look like it's not narrowed. Because typically a coarctation lives in that postductal area, kind of in that preductal area before the PDA. They can be postductal, but they typically live just in and around the PDA. So the PDA usually is either backflowing blood to it or it's going forward to it. And so the key things to this is these typically present as the PDA closes. So these typically present, and then once the PDA closes and they have a significant coarctation, these kids present in cardiogenic shock. So usually about day 3 to 5, if these are missed in the hospital, the kiddo comes back and is in cardiogenic shock and very, very sick. So the hallmark of these is that you have a difference in your blood pressure between your upper and lower extremity blood pressures, and you have a difference in your pulses, okay? So this, the kind of stands a good pickup with a pulse ox screen before they go home from the hospital, and picking it up in utero. This is going to be the kiddo that shows up after a normal discharge at day 2 of life, shows up to the ER at day of life 5, is breathing very fast. The parents state are not taking feeds, are not wanting feeds, they're breathing, they're bobbing their head, they're sweaty, their color is not good. If they have a murmur, what they typically will have is a systolic murmur that is heard radiating to the scapula. Sometimes you don't even hear it in the front, you actually just hear it over the scapula. And that's because your arch comes up, makes a turn, and then goes down the back. And so usually where that obstruction is in the back portion, kind of right in that scapular area. And so a lot of times you hear just this right there. And that on exam, they have very strong brachial pulses, but very weak pulses in the femoral. Sometimes little color changes, sometimes they won't. They usually just come a little pale, a little cold in their extremities. So this is important because if we catch this early enough, we can start prostaglandins, we can keep a PDA open, and we can keep the baby until we can do surgery. If they get picked up so late that I can't start prostaglandins, then that's very difficult, okay? There's also kind of the non-real severe ones that cause cardiogenic shock. but the kiddos that have a discrete coarctation, but somehow they form collaterals around it, and so they don't get picked up ever until they get, that kiddo gets about 3 or 4 when we start doing blood pressure screens in the pediatrician's office. And the reason that is that you have to feel pulses. So every time a kid comes to your clinic, you have to feel pulses. Because by the time that kiddo is 3 or 4, or the kiddo that's 9 or 10, or 17 or 18, and we're finding a coarctation, then they've developed a lifetime of obstruction in there, and they've got a thick left heart, they've got high blood pressure, that even once we fix it, they're going to have a lifetime of having high blood pressure, versus the baby we fix that can live a pretty normal life, okay? Probably already covered all of this. So typically we fix a coarctation through what we call an end-to-end anastomosis. So basically, if this is a coarctation, what they do is they go in and they cut out the narrowed portion and they pull the aorta together. There are some other forms of fixing it, but that's kind of the most common for just a discrete, and that's typically done through a lateral thoracotomy. So there are some other ones, and we're doing more and more of them through the front when they're kind of a long segment, so instead of a little pinched off area, it's kind of diffusely small, and the surgeon then goes in through the front and basically will rebuild the aorta. This is what it looks like on cath. This was probably an older kiddo who got picked up late, because that's a big aorta. So this is what aortic stenosis looks like. We've talked about this. So this is your subaortic membrane that you see. I'll use the thing. So this is your aortic valve. That little membrane right there is your subaortic membrane, so you guys can see it. So your PDA, everybody knows what a PDA is, right? So that's the connection between your aorta and your pulmonary artery. And so those can be very important in some lesions, like we talked about with the coarctation. Also, when they don't have blood flow to the lungs, with like a pulmonary atresia or a transposition or a total anomalous pulmonary venous return, those are all important that we have what we call ductal dependent lesions. They need the PDA open. So I always tell people, you give prostaglandins to keep a PDA open, okay? The other thing we talk about then is, well, what happens if the PDA doesn't close in the normal 72 hours of life? So in a term baby, it's very hard to give indomethacin to close the PDA, okay? So typically when we're talking about giving indomethacin, we're talking about using that on preterm babies. Every once in a while it will work if you do it in the first couple weeks in a term baby, but it's not very successful typically in a term baby. They've also started using Tylenol to close PDAs, but for the sake of, I don't think PA boards have caught up with that yet, so for the sake of that, I think you can just say indomethacin or neoprofen will close your PDA. But just so you know, if you read an NICU report, they are using that. So. The other thing is if they stay open despite indomethacin, or in a term baby that indomethacin won't work, they stay open down to about 1.5 kilos now, we can close those in the cath lab. And other than that, we can have the surgeon do it. Really tiny incision, kind of right here. They just go in, they collapse that lung, and they just go in, they tie off the PDA, and then they're done. So it's really, really fast. It can be done at the bedside in the NICU. All right, so that is PDAs. I'm right at kind of 55 minutes. Do you guys want to take a quick potty break, get a drink?
Yes.